Hey everyone, Dr. David Clark here. Today is another case study that we're going to walk through from my office. Today is a 50-year-old woman with Meniere's disease. So of course she's having vertigo attacks, experiencing hearing loss, but also having extreme fatigue. So she's having these random episodes of rotational vertigo and vomiting, so they're bad enough that it causes her to vomit. And the most recent was a few weeks before she consulted with me. This is happening mainly in the right ear, and she's having hearing loss in that ear. And the extreme fatigue started a few months ago. So we don't know if the fatigue is connected with the Meniere's disease or not, but we're going to find out. So we're going to walk through this case. I'm going to show you how I work it up, why I do the things I do. We'll find out what kind of treatment that I did for her. And again, I'm showing you these case studies because I think it's important for people with Meniere's to know that there are other ways to approach Meniere's, right? What the research literature shows and what happens in the offices of ENTs that are well-meaning is not always the same thing. And so we're just going to show you how I approach this and see what kind of results that we get. All right, so let's look at the history, right? History is really important. So in 2000, she had some infertility. She had intrauterine insemination treatment, eventually got pregnant in 2003. Now, while pregnant, she was diagnosed with hyperthyroidism and had toxemia at the end of the pregnancy. Now, this is important for me because she wasn't specific, didn't have the records, but this hyperthyroidism could have been Hashimoto's thyroiditis, which can create temporary hyperthyroid symptoms, but chronically creates hypothyroid. Hyperthyroidism could have been because of a toxic multinodular goiter, could have been Graves' disease. She really wasn't helpful, bless her, in figuring out what the exact etiology was. But nonetheless, that makes me think about her immune system, right? Now, she was recommended to do radioactive iodine therapy, which means she probably had Graves' disease, is what I would bet that she had. And subsequent to the radioactive iodine therapy, kills off the thyroid gland, she had to take Synthroid, right, which is just replacement thyroid hormones. In 2021, she had some fibroid tumors noted as well as cysts in the breast, so that implicates some hormonal problems, probably excessive estrogen or lack of progesterone. And then in 2022, she had her last menstrual period and also began having night sweats and hot flashes and irritability, which is, perimenopause. And she was started on hormone replacement therapy, including estrogen, progesterone, and testosterone. Now, the thing to remember about this pregnancy symptoms and the menopausal symptoms is that autoimmune problems also love to start at these same times. So me, using the kind of approach that I use, I'm always really interested in a Meniere's patient in what is going on, if anything, with their immune system. And I'm already wondering in her case what's going on because there's some little, tantalizing bits in her history. Now, in March of 2023, she had a hysterectomy, including the ovaries. So in June of 2023, she took a trip to Mexico, and on that trip, her right ear became stuffy and she had difficulty hearing. She came back and was given some oral steroids about a month later because the stuffiness didn't stop. Okay, so she goes to Mexico, and for whatever reason, ear becomes stuffy, and then it stays stuffy. And so she's given some oral steroids, which is kind of, a classic first-line thing. Why? Because steroids are anti-inflammatory. Now, they're not the be-all, end-all, and they only have about a 60-day window of efficacy, but that's a typical thing. Now, in August, 2 months later, she's clinically diagnosed with Meniere's disease. I want to make a point about that. And she was given intratympanic steroid shots, which mean they stick a needle through your eardrum and they put steroids right into your ear. And sometimes those can be very helpful because it's very localized, right? It's not oral circulating, it's very focused. Now, the reason I say clinically diagnosed is because there is no test for Meniere's disease. Meniere's disease is based on the doctor's judgment, right? If you've got more than 1 or 2 rotational episodes of vertigo, aural fullness, hearing loss, you're probably going to get diagnosed with Meniere's disease. Now, I'll let you know there are some, not really doing it a lot in the US yet, but there is some imaging that is possible, like some MRI type imaging that can actually investigate and look at your inner ear. And there are some pretty good criteria that you can use to judge what that MRI looks like and find out, oh yeah, you actually do have, high drops, right? Endolymphatic high drops. Hearing loss only at this time, and she felt that those injections did help somewhat. Now then she was exposed not long after that to some loud noises at a concert, and then she had tinnitus in her right ear. And what loud noises are traumatic, right? Those high decibel things. And so you've already got increased pressure, which puts pressure on the hair cells, and then you get acoustic trauma on top of that, can be enough to kind of push you over the edge, because that trauma is also inflammatory. Okay, so one of the things people don't think about is that when you get exposed to really loud noises, that tinnitus you get from that, what comes also along with that loud noise exposure is inflammation in your inner ear. So in September 2023, she had COVID-19. Well, here's another really inflammatory thing that happened, because COVID-19, whether you have a mild case or not, is very, very, very inflammatory to your immune system. And it loves on its own to stimulate autoimmune problems, whether you had a genetic predisposition or not. So we're definitely going to be interested in that. And also, right around that time, right after she had COVID, she had the onset of hair thinning and hair loss. I can tell you that there's any number of reasons that it could have done that. You can get something called telogen effluvium, which is where you shed a bunch of hair, usually about 3 months after a stressful event or an illness. Inflammation in itself, it could have been autoimmune, could have been hormonal based, a lot of things. Now she did try finasteride and minoxidil, and I'm assuming what those are. Those are 5-alpha reductase inhibitors. She was told, well, hey, this looks like kind of an androgen-based hair loss. And she did have a biopsy, again, that showed some sort of alopecia. I don't know what that is. She wasn't able to get the records for me, so I really don't know what the biopsy showed. But I'm seeing lots of inflammatory things again. So in March of 2024, she had an ear infection. Guess what that is? That's also going to be inflammatory, going to increase pressure. She had to take 2 rounds of antibiotics to get rid of it. But she didn't have any vestibular or auditory symptoms at that time, which is interesting, okay? Doesn't really mean, it doesn't exclude anything, but that's another inner ear inflammatory, middle ear inflammatory problem. And then she began taking semaglutide for a few weeks. She visited Mexico again, and her ear was stuffy again. So I don't know if it's the airplane trip. I don't know if there's an environmental allergen, but something's going on when she goes to Mexico. Then in May, she stepped off the treadmill and felt very dizzy, right? Kind of disequilibrium, unstable. And she had felt very tired for a few days prior to that. The next day, she had a rotational vertigo episode, terrible nausea, became what we call vasovagal, and vomited, went to the ER just to make sure she wasn't having a stroke, and the CT scan was normal. May 20th, vertigo episode again. May 21st to May 26th, on and off, very, very dizzy. It's not clear whether she was actually having rotational vertigo during that time or not. And then on May 24th, in the middle of that, she had another intratympanic steroid injection, okay? And just a day later, she began feeling better. So she is responsive to steroids, which tells you there's something going on with her immune system in her ear. Father has type 1 diabetes and Parkinson's disease. He died at age 67. Type 1 diabetes is an autoimmune condition. So she has a first-degree relative with an autoimmune problem. Odds go way up that we've got something significant with her immune system. Mother had a heart attack at age 69. She has a paternal aunt with Meniere's disease. Now that raises the specter of it being genetic. Genetic Meniere's disease is not common at all, and the people that do have it, I think the kind of the quorum is that those people tend to have structural abnormalities in their inner ear that predispose them to Meniere's disease. Now we don't know that she has that at all. We don't know if she has any genetic cause for it. And a paternal grandmother with type 2 diabetes, but that could be lifestyle related. So currently, when I consult with her, what she's taking is the hormones, levothyroxine and liothyronine, that's T4 and T3, and triamcinolone, which is a diuretic, magnesium, which I don't have a problem with, shilajit, which is an Ayurvedic medicine, which may or may not be doing anything, we don't know, vitamin D, which I don't have a problem with, Zofran and meclizine during the vertigo episodes, because Zofran is anti-nausea and meclizine is a vestibular sedative. They're not going to fix anything, all right? So what is her diet at the time that I see her? Well, she is not restricted at all on any foods, okay? She's eating whatever she wants. Now that means also she's not a low sodium diet either. She does have a few symptoms consistent with low HP axis tone. I mentioned that because that could be a factor with her fatigue. We don't know yet. So what do we do? So what do we know? Well, we know that she has Meniere's disease in the right ear. We know that she has previous hyperthyroidism. And that's probably autoimmune. Definitely an autoimmune family history. She had COVID-19, ear infection, lots of immune system stuff, right? Lots of inflammatory things going on. And so I want to know what is her immunophenotype, okay? You guys probably don't, I don't know if you remember this, but there's basically 4 priorities that I want to look at in every patient. In reverse order, they are, number 4, GI liver. Number 3 and 2 are all about energy production, such as glucose regulation, HPA axis tone, anemias, mitochondria. That's not super relevant in a lot of Meniere's cases. The blood sugar certainly can. And then number one on my list of 4 priorities is what's this person's immunophenotype? What is their immune system doing? So let's see what this testing showed us. So, but I want to mention, just before that, after our initial consultation and while we were waiting to get regular blood work done, she had 2 more debilitating vertigo episodes on June 6th and June 7th. All right, so she's not out of the woods. All right, so regular blood work. This is the non-exotic stuff, but stuff that's got to get done. So hemoglobin A1C is a little bit high. It's 1/10 of a point higher than the range. What does that mean? Well, it may not mean anything, but technically that puts her in pre-diabetes. But what does that mean? Well, it means that for 3 months, her blood sugar has been a little bit higher on average than it should be, probably. But what does that mean? Well, that's inflammatory is what that is. And again, remember, with Meniere's patients, the one thing that I see again and again and again and again is there's something going on with their immune system. It's not always the same thing. Sometimes it's autoimmune, sometimes it's not autoimmune, sometimes they have a chronic infection, sometimes they have an immune deficiency. But when someone's blood sugar is chronically high, and hers is, that's inflammation. C-reactive protein cardiac, well, here's what that is. Let me go through the rest of these things real fast. Okay. Now, so C-reactive protein cardiac, that is a general inflammation marker. It's just sensitive. It doesn't mean her heart's inflamed. I know the cardiac thing makes it sound like that, but they use that number. The reason I call it cardiac is to predict future relative risk of cardiovascular problems, okay? But my purpose is that it's a more sensitive general inflammation marker, and hers is a little bit high. Now, reverse T3, the reason I care about that is that really has nothing to do with her thyroid hormone levels. I'm pointing it out to you because when reverse T3 is elevated, one of the things that can do that is inflammation. Okay, so you see what we're doing, right? We're kind of building a case for inflammation. And then this last thing, immunoglobulin A. So immunoglobulin A is primarily, it's antibodies, and it's primarily made at mucosal surfaces. So the GI tract, the sinuses, the lungs, that kind of stuff. And hers is high. So we've got 4 pieces of evidence that say this is inflammatory. Okay. Now I'm not saying autoimmune yet because I don't have specific tissue antibodies to look at. So inflammation, name of the game. If I didn't know anything else about her, I'm going to try to de-inflame her as much as I can and see what that does for her. Okay, so this is the multiple tissue antibody panel. And one thing you'll notice is all of hers are green. Right? So the reason I do this panel is to try to get some assessment of, in terms of autoimmunity, can we figure out what her immune system is targeting or not targeting? Well, she doesn't have any of those. And then the bottom half of the panel doesn't have any of those. So she doesn't have any of those autoimmune problems. Feel pretty confident saying that. Now, that is not an encyclopedic list. There are plenty of things that she could have that are just not on that test. But you could spend $100,000 testing all available antibodies, and it's really not that necessary because this test right here is going to help me get half of the answer, what is going on with her immune system, right? And so far, I don't see any tissue autoimmunity happening. So I need to look at her lymphocyte map to try to give me some context for what those antibodies or the lack thereof are showing me. So again, this lymphocyte immunophenotyping is kind of like getting your immune system fingerprinted. It's a way of trying to find out, in her particular case of Meniere's, what is her immune system doing and what do I need to do to specifically address her immune system. Phenotype just means what does something look like, and immunophenotype means what does your immune system look like. And we find that out by looking at T cells and B cells and natural killer cells. And rather than giving you a big lecture, let me just show you what I gleaned from this. So you'll see that her percent lymphocytes up here are a little bit low. That's not really telling, to be honest with you. You see that her percent CD4 are a little bit elevated. So what that means immediately is that her immune system is a little bit turned on. Now CD4 T cells are kind of generic. They typically can become T helper 1 cells or T helper 17. So let's look and see what happens. So if I then look at this next batch of results, you see that our T helper 1 is elevated, T helper 2 is elevated, but the ratio between them is kind of normal. Now, I'm not going to get fooled by the ratio because, her TH2 is definitely high. I mean, it's double what it ought to be. And her TH1 is certainly high. So what does that mean to me? That means to me, her immune system's turned on. It's activated. It's stimulated more than we want it to be, right? And what that is, if you want to think about it in simplest terms, is you can think of that as inflammation, okay? In simplest terms. Now, the next thing you'll see is that her T helper 17 are low. And basically, some people are kind of genetically programmed to have T helper 17 low. And it's, I mean, kind of better than if they were high in some regards, because really what that can predispose you to if they're low is, perhaps GI microbial overgrowths or other mucosal surface overgrowth. But she's not really known for having chronic infections. Certainly she had an ear infection, she had COVID. And then the next thing that we'll see is that her cytotoxic natural killer cells are slightly elevated. So long story short, to me, in broadest terms, this is an immune system that's turned on. Doesn't look all that autoimmune because we're not seeing a real asymmetry in T helper 1, T helper 2, but our immune system is certainly still activated. I don't think there's a chronic infection happening. So CD4 is increased, Th1 and Th2 are increased, Th17 is low, and to me I'm thinking, look, we got an inflammatory problem without known specific tissue antibodies. Okay, so here's the treatment plan. We're going to de-inflame, right? I'm going to de-inflame as fast and as hard as I can and find out what does that do to her symptoms. So we're going to put her on, you guys heard me talk about this before, a short-term, perhaps even long-term anti-inflammatory repair diet. Definitely going to be low sodium. Right? That's such a low-hanging fruit. As I've talked about before, I have some other videos on this. Low sodium is important for Meniere's patients because wherever sodium goes, water goes. And if you have a confined space and you're bringing more fluid into the area, the pressure is going to increase and can contribute to symptoms. But also, sodium above a certain threshold, which is individualized, is inflammatory. So we're definitely going to do this. And then we're going to use the supplemental protocol, which I'm not going to tell you guys what it is because I don't want you treating yourself, but that's based on my experience and what I think would work the best for her at this stage. So after 30 days, she's been vertigo and symptom-free for 75 days so far. Now, I can't take credit for that, so to speak, because that means she had already been somewhat symptom-free for a few weeks before we started the 30 days of treatment. So what do we do? Well, I'm not going to change anything except she's begging me to reintroduce eggs because her life would be easier because eggs aren't allowed on that anti-inflammatory diet. I say, give it a shot, right? There's a way you do that. And your response or lack of response can tell us a lot about whether that's safe for you. So I say, hey, go for it. Try to reintroduce eggs. So what are we testing when we do that? We're basically testing her GI barrier and some other things we're not going to worry about. We do need to recheck her cardiac CRP because that was our inflammatory marker, and I want to see if that's gone down. And we did. And that's now normal at 2.7. So remember, it wasn't super high to begin with, but what we did de-inflame her. Okay, and we're going to continue the remainder of that anti-inflammatory protocol. After 90 days, this particular patient, I'm not going to say she's not the most compliant, but she tends to kind of drift away and then drift back a little more loosely than I would like to because I like to keep tabs on people, at least early on. Anyway, but after 90 days of treatment, still symptom-free. Okay, that's good. No vertigo episodes. And reintroducing eggs was not problematic, so those are back on the menu. So now we're going to fast forward a few months. Now that's why I told you about her kind of drifting in and out. So we're going to fast forward a few months now, and after 8 months of that treatment plan, she's feeling good and having no fatigue. So feeling good means no vertigo episodes since the previous June, right? So this is going to have been the following February. So who gets the credit, right? What gets the credit for this good response? I'll tell you the reality of it, right? The reality is that Meniere's fluctuates, okay? And sometimes when you're me, you have to be careful you don't give yourself or your approach 100% credit because Meniere's does fluctuate. And maybe when she had that big flare-up right before she saw me, maybe the intratympanic steroid injections, maybe that kind of, slowed things down, and maybe Meniere's has just been, not fluctuating since then. But I will say that I think the low sodium diet and doing that anti-inflammatory protocol, we know it did de-inflame her just based on the lab results. So I know it didn't hurt. But the longer she stays symptom-free, okay, I don't really care who gets the credit. I mean, you know what I'm saying? Like, I really don't care because I just want her to get better and stay better. Now, of course, for me as a doctor trying to do the best for my patients, I want to know what works so that I can, refine my treatment approach, but I don't really care. I don't really care if it's, medication or the hormone therapy. I really don't care. As long as she's doing better, great, because that's really my job. I'm not writing research papers, although I wish I could. I just want her to get better and stay better, and that is what she's doing. So why do I show you this particular case? I show you this case because, a lot of people kind of get to the place where they feel like they're just going to have to live with Meniere's, right? They don't feel like they're getting many options. Sometimes people are telling them their diet has nothing to do with it, and that's just not true. I'm showing this case just to give you a good example of what is possible in Meniere's disease. Now, does it work for everybody? Of course not. And again, I'm not taking full credit for that. It could be that we happen to treat her during the time of a normal ebb, or a waning of her symptoms. But, we're going to follow over time. I'm still following over time and keeping in touch with her so I can feel, because I want her to get better. And so I want you to know that that is possible, right? It is possible. But you got to do the right things, right? You got to work with someone that knows what to do. So don't try to treat yourself. I really don't want you to do that. It's too complicated and too easy to mess yourself up. And I also show you this just so you can have some hope, right? People with Meniere's have a pretty terrible quality of life when they're symptomatic. I mean, and it's terrible and sad and depressing. And it doesn't have to be that way, but it doesn't work for everybody by any means. But I think it is worth investigating for sure. Okay, I'll see you guys next time. Have a good one. Bye-bye.